This is the Let's talk about diabetes, and we all know these types: type 1, type 2, gestational diabetes, and 1 or 2 or gestational. This is the disease is inability to metabolize the glucose and reaching to the level of hyperglycemia. That's what diabetes is. It's not really insulin disease. Well, it is an insulin disease, but what you're concerned about is hyperglycemia. You have high blood sugar or high blood glucose level. The gestational diabetes may resolve, although we know it's basically becoming common knowledge. If patient had gestational diabetes, they may end up with type 2 diabetes later on in their life. There are many ways to diagnose diabetes, and especially type 2 or even type 1, but most diagnostic will be 2-hour post-glucose test or glucose challenge test. You may have need PhD in math to calculate this, just kidding, but this involves an algorithm of calculation in 2 hours after loading patient with certain amount of glucose. You may check fasting glucose, and if patient presents with glucose level of 126 or more, above 125, this may be diagnostic for diabetes. A1C is glucosylated hemoglobin. A1C is not diagnostic. However, this is a good tool to monitor the progression of disease or monitor the treatment and response to treatment of this of patient with this. So type 1, there is a theory that genetic susceptibility common. However, there is no strong evidence suggesting that, but of course some patients will be genetically susceptible and may develop this. Usually there is some kind of trigger, as an illness, viral disease, or even autoimmune disorder that may start the destruction of beta cells, and this is usually immunologically mediated. So in type 1 diabetes, the beta cells destructed or destroyed, and this is quite rapid process, and patient has to have some type of trigger for this to occur. Twin studies have been done, and in twins the probability or likelihood of having diabetes type 1 in one twin, it doesn't mean then second twin will have high probability of having it as well. So one of the twins may have type 1 diabetes, the other one can be healthy. When we're talking about type 1, again, it's hyperglycemia, it's our main concern. The beta cells are dying or dead already, and beta cells are in isolates of Langerhans, of course, and we are losing the functions very rapidly. There are 3 P's for diabetes. Doesn't matter type 1 or type 2. It's polydipsia, polyuria, polyphagia, and there are 3 P's of diabetes. So patient drinks, eats, and urinates a lot, and this is all related to the metabolic dysfunction patient is experiencing. For instance, polyuria is a direct consequence of having too much glucose in the blood and having increased osmolarity, and which may result to fluid excess intravascular fluid excess and need to urinate or need to get rid of that fluid. Polydipsia is consequence of this, and polyphagia is patients need to eat because sugar or glucose isn't utilized, and patient constantly feels hungry. And another player comes into this game, and that other player is fat. Patients with diabetes type 1 will start losing fat, or they will exhibit with weight loss because fat starting to be broken down as a source of energy, and that will result in ketosis, or ketones in the blood and urine, because ketones are byproduct of the fat breakdown. Type 2 diabetes may affect adults and children, and main thing here, it's not destruction of the cells in isolates of Langerhans, but main thing is resistance of target cells to insulin. Its inability to accept the insulin and glucose. In this point, the age for diabetes type 2 getting lower and lower, and many blame the obesity, and which is true. And the more adipose tissue we have, the less sensitivity is to insulin, so patient is desensitized. This will affect both adults and children, but with age the risk for diabetes type 2 increases. Genetically, again, twin studies have been done. In this case, if one of the twins is having diabetes type 2, then the other twin will have it. The probability of it is highly likely. Also, environmental interaction is, of course, playing a role. Having excess weight facilitates having diabetes type 2, but again, there is a strong genetic component. So with addition of environmental factors such as obesity, the patient likelihood of developing of diabetes type 2 increases. Metabolic syndrome is a triad of hypertension, hyperglycemia, and hyperlipidemia. In this triad, patient will have increased blood pressure, and some call it pre-diabetes, which is not one of my favorite terms because it's either diabetes or not. So metabolic syndrome is a better term. In metabolic syndrome, diagnostically, fasting glucose should be from 116 to 125. After 125 is diabetes, but 116 fasting glucose tells you that this patient is at risk of developing diabetes. This is a good time to get on your soapbox or whatever and start screaming and trying to educate your patient about introducing lifestyle modification and weight loss exercise. This all are good players in this. And also a patient, if they introduce or if they present with hyperlipidemia, they would need treatment for that, and hypertension also needs to be controlled. But again, pre-diabetes, it's not a good term. Metabolic syndrome is a great term, and it's not only a great term, it's a great billable term. There's a code for it, and some call it syndrome X. But these three, again, hypertension, hyperglycemia, and hyperlipidemia go together, and this is a warning sign. It's a flag. It's not something like, oh, you have pre-diabetes, but it's not full-blown diabetes, so we still have time. No, we don't have time. We need to get on this as fast as we can. We need to start working on this. We need to start teaching this patient all the good things we know and all the bad things we know about diabetes, and try to prevent a development of full-blown diabetes type 2. Um, Patient with diabetes type 2 will have overall representation of sickness. So the patient may have recurrent infections, vision problems, and neuropathy, and this is all consequences of end organ damage secondary to hyperglycemia. So treatment here is very nice, and exercise, treatment of obesity, and introduction of medication. And by medication we mean not only oral medication, but in some cases patient may benefit from insulin in their course of illness. Please read this line for treatment, and it says treatment for obesity. Treatment of obesity, it's not panacea for diabetes type 2. If patient loses weight, it may be too late for patient to have the diabetes type 2 cured. So treatment of obesity, if it's introduced, patients have to have realistic expectation. Even their glucose control may greatly improve if they lose weight one way or the other, but they still may need some type of treatment, some type of medication, or at least diet, but they usually may need something like this. It's a common fallacy propagated by media and exercise industry and supplement industry that if you are not obese, you will not have diabetes type 2. If you are fat, you are doomed to have diabetes. Both statements are bogus. There is you cannot make blanket statements like this that there is 100% correlation of obesity and diabetes type 2. But of course there is a relation between obesity and diabetes type 2, and of course losing weight will help to achieve better glycemic control and to achieve better quality of life for this patient. The hypoglycemia may be a manifestation of diabetes mellitus secondary to overdose of insulin, and needs to be treated quite rapidly. And most of the time, I shouldn't say most of the time, it may be treated by introduction of oral glucose or glucose containing agents such as orange juice or intravenous injection. The key point here, if patient is unable to swallow, certainly this is not a good idea to introduce oral glucose in any shape or form. Diabetes ketoacidosis is a consequence of diabetes when ketone bodies are excessively accumulated in the blood, and patient becomes acidotic and may become comatose. In this case, introduction of intravenous insulin may be very helpful. Patient has to be treated in hospital setting, of course, for this, and monitor excessively. And patient also will need a more significant amount of IV hydration and intravenous fluids. And of course, diabetes ketoacidosis, DKA, is a significant medical emergency. Hyperosmotic hyperglycemic non-ketotic state, it's one of the consequences of diabetes, usually with type 2, can happen with type 1, and in this emergent situation, distinguishing sometime or blaming one or the other type of diabetes doesn't really have any importance, but however, this one may occur with type 2 may more often. In this case, in case of HHS, and I'm saying HHS because sometimes we're saying hyperosmolar hyperglycemic state, we do not usually see many ketones or at all. The problem here that needs to be addressed and treated is severe dehydration and potassium deficit, and again IV hydration has to be introduced, and the patient needs to be treated for potassium deficiency. Again, this may occur when the glucose or hyperglycemia is not under control. That's why it's important to emphasize the compliance of the patient and have them at tighter control if they have more or less complicated situations such as infection or they are having steroid treatments. When patient is having continuous hyperglycemia, they may develop the polyol pathway. When sorbitol and fructose increase, they will increase intracellular osmotic pressure, which will attract water, and basically cells will burst. This will happen in the eyes, nerves, red blood cells. Protein kinase C, it's another kinase enzyme that will be activated by hyperglycemia with all the consequences. But again, hyperglycemia is not good in this case because it's hyperosmotic effect and damage to the cells and damage to the nerves and red blood cells secondary to osmosis. Patient may develop microvascular disease, retinopathy, and also patient may develop diabetic neuropathy. Retinopathy may be a consequence again of hyperglycemia, and also nephropathy does work the same way. In case of nephropathy, patient will have albuminuria secondary to glomerular damage, and also we will be losing more and more glomerular units in here. Unfortunately, diabetes nephropathy is the #1 cause of dialysis placement in developed countries in Western world. Retinopathy also may be, not maybe, but it's one of the leading causes, and it is the leading cause of blindness in working age adults in the United States, and is secondary to diabetes mellitus. That what happened in retinopathy, the blood vessels in retina damaged more and more, and there's more and more swelling occurs, and more blockage occurs. So that will be our primary retinopathy. In the case of secondary, when patient will start developing new vascular bed, new vessels to try to combat the already damaged vessels in the eye, and this may lead to exacerbation of the disease. So again, diabetes, the consequences can be grave, not only because the reaction or because of direct consequences of hyperglycemia, but also the damage to end organs. Macrovascular disease and endothelial damage results in coronary artery disease, and even though it's not the highest morbidity, but certainly it's the highest mortality cause for patients with diabetes type 2. the longer patients have diabetes type 2, the more chances of dying of cardiac disease are there. Also, patient may have strokes and peripheral artery disease. In case of diabetes, again, we are dealing here with endothelial dysfunction, endothelial damage, and as a consequence, patient may develop coronary artery disease, or if we talk in general, patient will develop vascular disease, which may include coronary artery disease, stroke, and peripheral artery disease. Neuropathies are quite common in patients with diabetes, and neuropathies will lead to many other negative consequences, such as diabetic foot ulcers or Charcot joints. Neuropathy is something that need to be addressed either by medication and also by frequent inspections by their healthcare providers as well as the patients. Patients certainly will be more susceptible to infections when they are experiencing diabetes mellitus. At the same time, patient may have combined negative consequences of neuropathy and infection. Let's say patient has diabetes foot ulcer and didn't notice it, and this will get infected and will lead to amputation. Neuropathies may be also having a different origin as diabetes, as we talked before, as B12 deficiency. So if patient present with tingling, numbness, paresthesias, this may be, it's not like carte blanche saying, oh, you have diabetes, you have neuropathies, let me give you some Neurontin. It may be consequence of B12 deficiency. So thorough diagnostic workup is certainly will